and welcome to another Piper Pod. Today we're going to continue with pathophysiology, and we're going to look at conditions that affect the skin itself. Now there's literal thousands of conditions that can affect the skin, so obviously this one is going to be more of an overview of classes and a look at some generalized conditions that you can find. And what makes skin conditions particularly difficult is a lot of the pathological conditions will overlap. You'll have a mixture of infectious versus inflammatory versus immune versus congenital, and then you build in the complexities of certain irritants as well. With all that in mind, this presentation is not going to cover a huge amount of detail because it would just be too long. So the focus will be overview, couple of tricks that you can look at in order to understand the entire pathophysiology of the integumentary system. So we'll start off just with a little bit of review. I recently realized that I didn't actually do a anatomy physiology of the integumentary system, so we'll just have a quick look at the structures and the function of the skin before we move on to the conditions. So the skin, as you're all acutely aware, is the largest organ in the human body, and it accounts for about 15% of your total bodily weight. It's broken up into three layers called the epidermis, the dermis, and the hypodermis, or subcutaneous tissue. The epidermis is a series of layers of cells, mostly made up of keratinocytes, and they arrange themselves in different layers. There's about 7 layers of these particular cells. And then throughout, we have other cellular structures like your melanocytes as well. So once we move down into the dermis, this is where all the connective tissue will come into play. And this is the area that is most involved in inflammation and cellular proliferation. So there's a lot of blood vessels, nerves, and then we have our specialized structures or the appendages to the actual skin, like hair follicles, sebaceous glands, sweat glands, could be either your eccrine or apocrine sweat glands. The difference being eccrine is the ones associated with heat, and the apocrine come around during puberty and then help put lipid-based substance into the actual epidermis in order to waterproof and harden the area as well. So it gives it that little bit of extra layer. And then the sebaceous or the hypodermis is your fat tissues. Okay, so it's just filled with a protective layer of fat tissue itself. When we talk about the function of the skin, it protects the body against trauma. So if you were to just bump your arm or anything like that in the absence of skin, the internal weaker structures or far more fluid-based structures would be destroyed. Okay, so they have a huge amount of keratinized layers around the skin. Obviously a lot thicker in places like the palms of your hands, the soles of your feet, but this keratinized layer helps keep your body safe. It plays a huge role in regulating body temperature through sweating, obviously through the vasodilation and the use of sweat glands to aid in evaporation, and then you've got your insulation layer of sebaceous tissue. Immunity is another thing that it does, so it has its natural impregnable force field, if you will. This is slightly acidic, filled with lysosome activity that can break down certain infestations. And then it also has resident macrophages that will actually live around the dermis or can be attracted to the dermal areas by chemotaxis and things like that. Its nerve endings are associated with sensations or pleasure stimulants, and it also has a massive role to play in the synthesis of vitamin D, which is obviously vital for the regulation of calcium stores. So that's, generally speaking, all the things that the skin does. And what it has to protect us, and we'll look at a few of the conditions that we'll look at the different layers and how pathogenesis will cause changes in those layers that will give us clinical symptoms that we can find. Okay, so the first thing that we are going to focus on is external injuries. So we're not going to focus on wound healing or anything like that, because we've already sort of looked at that when we dealt with inflammation and that sort of thing. So external injuries can be mostly described by a mechanical injury or some form of forces that have placed pressure or damaging particles on the exterior surface of the skin that will cause a problem. So a pressure ulcer is an example of a mechanical injury. It's also called the decubitus ulcers as well, and it happens generally when an area of the skin overlies a bone and therefore is subject to pressure from external sources. Okay, so when you have a pressure placed on to the skin, which is in turn pressing onto bone or a harder surface on the inside, then it has a chance of creating a pressure ulcer. Now, if a person is more susceptible, then this phenomenon is more likely. So certain contributing factors, the amount of pressure that's put on them, the poor circulation, people with poor nutrition or sensory deficits, so obviously they can't feel the pain that starts a pressure ulcer. And then you'll also have things like shearing forces, friction, which is, a shearing force is a way of saying if you stretch the skin out further, then obviously you're already going to have a decreased ability for circulation in that area, which is going to lead to more likely pressure ulcers. And if you get friction, so movements back and forth or rubbing over a constant stimulus, then you're going to get cellular destruction, which is going to increase the inflammatory process, but in the absence of high flow circulation. So you get pressure ulcers, you build up of toxic substances, which ends up killing the actual cells, causing them to ulcerate. Now, moisture is something that is a little bit more complicated because the skin needs a certain amount of moisture and hydration in order to function, and if it's dehydrated, it's more likely to get a pressure ulcer. But if it is like saturated, like if someone's wet themselves and therefore they're sitting in moisture a long period of time, that moisture is going to soak into the skin and then degrade or cause hypertonic cellular structures, which in turn is going to make them weaker and is going to have less ability to actually repair itself. So there's some risk factors associated with it, and what we want to do is we want to try to prevent pressure ulcers as much as we can, because treatment of pressure ulcers is very, very difficult to achieve. So things that we can do is we can ensure that the patients have adequate nutrition, we can keep moving them regularly, and we can check for early signs of degradation, or we can avoid shearing forces or friction. In the event there are ulcers, then we can treat them early and monitor them so then they don't end up being full-time necrotic and therefore lead to much further complications like osteomyelitis and things like that. Another type of external injury is burns. Now, I know that we focus a lot on burns from a trauma sense, so this time we're just going to look at burns from more of a clinical sense. So a burn is obviously damage to the skin caused by exposure to extreme temperatures, hot or cold, and also non-thermal injuries like friction, chemicals, or radiation. Okay, so that's the classification of a burn itself. Now, when we're assessing the burn, it's obviously the depth of the burn and the extent of the surface area is what we look at. So we have first, second, and third degree burns, or superficial, partial thickness, and full thickness burns. So first degree burns is just damage to the epithelial layer. Okay, very superficial burn. Second degree builds into the epidermis and part of the dermis, so it starts to involve the hair follicles and basically those sebaceous glands and that sort of thing. When we get a third degree burn, it's full thickness. So all the dermis, all the epidermis, and part of the hypodermis is gone. So we have a dry, leathery appearance, lack of sensation, and it really degrades the amount of healing that is viable. So secondary intention always comes into play, and you're generally left with a huge amount of scar tissue, and this often requires skin grafting. Now, second degree burns are obviously a little bit different. They can occur from the edges, and you'll have minimal scarring as a result of your second degree burn. Now, there's a lot of arguments in that. Sometimes a second degree burn can have aspects of full thickness, which it will leave scarring, but a classic second degree burn will actually lead very minimal scarring itself. Now, looking back at our skin grafting technique, so those that haven't seen it, it is quite interesting, for lack of a better term, what they do. So they obviously peel a part of the person's skin off with what can only be described as a cheese grater, not a cheese grater, but a peeler itself. And then they push the skin through a machine that makes a matrix or a woven net out of it, and then they graft it over the top of the burns area, which will encourage that skin to bind to the area and then also spread through proliferation and cellular regeneration and things like that. So usually we're looking at skin grafts. Most of the time it's taken what's known as an autograft, which means the skin is taken from yourself or the patient's body itself. Okay, now in the event they can't do that, then they look at alternatives like an allograft, which is taken from an unrelated donor but of the same species. Okay, so it's not your skin, you have someone else's skin. And then you can have a xenograft, which is actually taken from a different species. Okay, so that can also occur. Now when you're looking at skin grafting, the most common type of skin grafting is what's known as split thickness grafting. So that's where they go for the whole epidermis, and the upper part of the dermis is actually what is harvested. Okay, so they don't take the whole dermis from the actual individual, because then that region that is taken it from is not going to be able to heal itself, because you've taken away, you've basically created a full thickness burn, but through grafting. So because of this split thickness grafting, what happens to the actual donor is the donor site is able to regenerate from the basal cells, and it has hair follicles and it has skin appendages, but the transplant or the graft site is the opposite, because obviously you've gone for the split thickness. Okay, you haven't included all the skin appendages, so the grafting site will often be absent sweat glands and hair follicles, things like that. Now, depending on the degree and surface area of burn, there obviously can be a significant amount of complications that can occur. Now, we've focused on these in the past in trauma, but things like infection and fluid loss are also a thing to consider, even during the healing phases as well. On top of that, you can have chronic conditions of electrolyte imbalances because of the inability to hold sodium mostly, and therefore creating a potassium-sodium mix that is not normal within the body. Hypothermia is also a massive consideration for burns, because you've lost that ability to regulate temperature. And then as part of infections, there is a huge chance of cellulitis as well. Okay, moving away from external injuries, we'll have a look at sunlight exposure. So when you are exposed to sunlight, it can lead to superficial or even second degree burns. It's mostly associated with chronic exposure causing cellular deformation and changes. So when we have acute exposure, it's similar to any type of thermal burn. Okay, you get vesicles, you get hyperemia as a result of blood vessels dilation to try to lose the heat within the dermis, and then it heals much like a burn. Okay, very little scarring, no formation of fibrous tissue, that sort of thing. Whereas chronic exposure stimulates the transfer of melanin pigment from the melanocytes to the keratinocytes, so you have this hyperpigmentation around the area. Now this results in atrophy of the actual epidermis itself, so the epidermis actually becomes thinner and therefore more susceptible to problems. And because of this constant atrophy and then hyperpigmentation and cellular changes, there is a risk of the development of neoplastic formations or tumorous growths within there. The underlying structures go through chronic inflammation, so they move from normal proliferation to chronic inflammation, and then all of a sudden you get these fibrous growths within the connective tissue because of the need for regeneration. Okay, so because of the constant destruction of the actual skin itself, it leads to chronic inflammation, which turns into fibrosis underneath the skin. So chronic exposure as opposed to acute, has obviously a very, very different appearance. Acute exposure is hyperemic, what looks like a sunburn, whereas chronic exposures is you'll have small patches of thick, scaly, crusty skin, which looks like your actinic keratinosis, which we'll look at soon. So different skin conditions will obviously, from exposure to the sun, will obviously follow a certain pathway. Now, as we've mentioned, actinic keratinosis is generally the first pathway that you see as a result of chronic exposure. Okay, so it's also known as your solar keratinosis. So as mentioned, its clinical features are your dry, atrophic skin with scaly red silver patches all around, and it's lost its elasticity. Now the problem, or the progression if you will, of actinic keratinosis is squamous cell carcinomas. So looking at the picture to the left at the top, your squamous cell carcinoma is an invasive malignant tumours of the epithelial layer itself. So it arises just on the actual superficial layers, and it's usually associated with dysphagia of your keratinocytes. Okay, so it is obviously caused by increased sun exposure, and its clinical features are persistent, like non-healing ulcers with this scaly crust all around it. It's locally invasive, so it looks like an ulcer that doesn't actually spread anywhere. Because it's non-healing, it can randomly bleed. Okay, bleed without bumping it, things like that. Now, as far as metastasis, it obviously has the ability to metastasize to lymph nodes in the surrounding areas, but it's not as common. Okay, so like less than 2% chance of that occurring. Unlike your basal cell carcinomas, which is the most common type of malignant skin tumours you can get. So this one here arises from deeper cells. Okay, so the deeper cells of the epithelials, so your stratus basilarum, is where these basal cell carcinomas actually will rise from. Now it is also caused by sun exposure, but it's not a progression. So you don't go actinic keratinosis, squamous cell carcinoma, basal cell carcinoma. It is a different formation itself. Okay, so just to let you know, so its clinical features is you have these slightly elevated nodules with a central depression. So it's like a cavity with nodules growing up around it. There's extensive tissues that looks a little bit like burrowing around it. Okay, so it's called a rodent ulcer. So the ulcer itself is in place, but it looks like something's growing up around it. Now, even though this is the most common form of malignant skin tumour, it does not metastasize. Okay, so it doesn't spread through the body, okay, and it rarely causes someone's death. Now, malignant melanoma, okay, which is obviously a very confusing terminology because it ends in oma, therefore being more of your benign type growth, is your most common skin condition that will actually metastasize to the rest of the body. So these tumorous growths originate in the melanocytes. The melanocytes are associated with being peppered around the actual keratinocytes. So 50% of all cases of malignant melanomas will arise from intact skin. So just skin that just looks like normal skin. Whereas the other 50% will arise from your freckles or your birthmarks, things like that. Now, chronic exposure to sun is a massive predisposing factor, and this one rapidly metastasizes through the body, into the bloodstream, the liver, bone, bowels, all over the place. Now, when you're looking at moles or melanoma type growths, we use the ABCDE a lot of the time, types of classification. We're not going to go into too much details, but we're looking for changes in asymmetry. We're looking at ill-defined borders, changes in pigmentation of the actual mole itself, and also the size of the actual melanoma growth. Another thing that can play a role in our clinical decision is looking at the history of the actual skin changes. Okay, have you had this hyperpigmentation for your entire life, or has it just recently evolved? Things like that. Okay, so that's your sun exposure conditions for the skin. Now we'll just have a quick overview, if you will, of infections of the skin, because obviously there are thousands of types of pathogens that can cause skin infections and therefore rashes and things like that. So we'll just look at a few of them. So impetigo, or what's classically known as your school sores, is a superficial bacterial infection. So it easily spreads over the area and even to different areas and can pass on easily to other children, hence why it's called your school sores. One kid goes to school with impetigo, all of a sudden there's a whole bunch of children that are infected by it. Now the clinical features is you have this blistering honey coloured crust. Now honey is obviously coming from the cirrus because it's just the superficial layers, and you'll get this crusting usually associated with the face or around joints. Now your funicles and your carbuncles, they're classically known as your boils. So these are bacterial infections caused by your Staphylococcus aureus, which is a very common flora that is found on your skin. Your furicles are essentially one hair follicle that is infected by this bacteria. So it's like one opening or one small boil. Whereas a carbuncle has multiple. So both of them will start with damaging to the hair follicles, therefore causing your folliculitis. When the infection spreads deep into the subcutaneous tissue, then you start to move from a folliculitis into these funicles or carbuncles. So obviously looking at that, it's common in the axilla, the groin, the buttocks of men, and also around the face. It also affects more the elderly and the diabetics. So as the infection spreads through the hair follicles, to change from a furnicle to a carbuncle, it's just the involvement of greater tissue and affecting more hair follicles itself. You get localized inflammation of the area as well. Now another type of mostly bacterial infection that we need to look out for, so obviously can be caused by other infections like fungi, that sort of thing, is cellulitis. Now cellulitis is defined as inflammation of the dermis and the underlying layers in the subcutaneous tissue. It's very common in the lower legs of adults and the periorbital region of children. It's caused by a bacterial infestation. Okay, so even in the presence of the athlete's foot, fungus gets in there, weakens the area, and the surface bacteria will come along and actually cause the infection. So sorry if that was a little bit confusing before. If you suffer from lymphedema, okay, so oedema caused by lymph tissue, then it's a big risk factor. Now obviously this is something that we see in the field a lot. So its clinical features is your localized pain, tenderness, swelling, erythema, warmth, and obviously it can lead to greater complications and often is associated with pre-sepsis. So when you're looking at a infection of the skin and you're deciding whether or not it is cellulitis, you need to take a lot of things into account. So you can have pre-septic cellulitis, and then you can have septic cellulitis. And you can also have a whole bunch of conditions that looks a little bit like cellulitis, but you just need to consider them. So first characteristics you need to find is the ones we just went through. Okay, so you have your warmth, your redness, slight edema, tenderness, plus or minus a fever, depending on how progressive it's gone. Think about the person and look at your other diagnosis. We're not going to go into too much detail, but you also have to test for any of the red flags. Red flags generally means the cellulitis is moving more towards pre-sepsis or sepsis itself. So if it's spread to associated lymph gland or the skin itself is so tight that it has a reduction in flow, therefore having a bluish purpley appearance, If there's any necrosis or ulcerations around it, then these are all big telltale signs. It needs to be evacuated from the field and treated quite aggressively. There is another condition that is like cellulitis, but only affects the epithelial layer. So erysipelas is just that. So when you're looking at cellulitis and you think it could be erysipelas, then you need to look for a high fever, okay, so over 39, and you have a line, for lack of a better term. So it's a really crisp line that you can actually identify. So unlike cellulitis, how it's more progressive around the entire underlayers, erysipelas is more of a fixed line of your dermatological changes. It also comes on quite suddenly, and it has a borderline in which you can actually palpate. Now, if you have those signs, then you need to up your ante in evacuation, because it needs to be treated slightly more aggressively than cellulitis. Okay, so just look out for those signs, especially when you're dealing with cellulitis in the field, because you need to pick it up nice and early. It needs to be treated early, and you need to look out for your alarming symptoms of sepsis, and you also should always consider the possibility of this erysipelas as well. Okay, moving from bacteria all the way down into viral infections. Viral infections of the skin can be quite difficult to pinpoint, because you have different clinical findings for different viruses. So your measles, you'll end up with a maculopapular rash all over the bodies, whereas your herpes will classically show vesicles. So chickenpox, herpes zoster, cold sores, that sort of thing, you'll have vesicles. And then you'll have your human papillomavirus that shows up as warts. Okay, so there's no telltale symptom of viruses that you can look for. So you just pretty much have to know a good broad spectrum. Now, viruses like herpes, they always say once you get herpes, you've always got herpes. Well, the reason it's true is because it has the ability to hide within the dorsal ganglion root itself. So during initial infestation of chickenpox or herpes simplex with cold sores, you'll end up with the vesicles on your body and your face. Then the virus will actually transfer along the peripheral nerve and set up shop in the dorsal root ganglion. Now, the virus moving into the ganglion can actually be quite destructive. So it's not just like it lays dormant, you don't have any symptoms. You can actually get necrosis and fibrosis, therefore destruction of nerve cells found along that entire dermatome as a result of these viral infections. And that's generally what causes the affected dermatome rash, okay, that you'll see classically in shingles. So when you have reactivation of these particular viral conditions, okay, it's usually occurs by as you get older, so if you get a little bit more immunocompromised, and then also if you're on immunosuppressive drugs as well. So anything that lowers your immune system, even stress, can bring it on as well. Okay, they often say that your cold sores be brought on by sunburn, increased salt, high temperature, and even during stages of the menstrual cycle you can get things like cold sores, whereas your varicella, herpes zoster, is more associated with aging and immunosuppressiveness by your stress or drugs, things like that. Now, if you focus on a classic case of your varicella or herpes zoster, in the event of reoccurrence, you'll have two different clinical presentations. You can have what's known as a pre-eruptive and then acute eruptive phase. So in the pre-eruptive phase, you'll get an unusual skin sensation along a particular dermatome, so numbness, tingling, or itching along there. When you get during the eruptive phase, you develop an extremely painful rash. Okay, starts with just general redness, and that progresses to vesicles. When those vesicles rupture, you get ulceration, crusts, and then healing with or without fibrosis. Now, classic clinical feature of this rash is that it doesn't blanch. So if you were to put pressure on it, it doesn't actually change colour. Now unfortunately these can move on to a chronic phase, which you'll end up with neuropathic pain, or post-hepatic neuralgia is what it's called, and that is sharp electric shock or burning sensation type pain that can be very, very debilitating. Now this can occur in up to 50% of all the zoster cases. So sometimes you'll just have the rash and it'll be quite benign, but 50% of the time you'll end up with this really debilitating pain that often results in hospitalisation. That is much higher incidences in the older population, but can usually last for 1 to 3 months. So something you can avoid. Now, this is obviously something that can occur to anyone who's been exposed to chickenpox before, and this is why over the years we've moved away from things like chickenpox party, because the reoccurrence of these disorders can have quite debilitating adverse effects. Okay, other conditions that we'll look at can include your parasitic infestation, so things like scabies. Now what these will do is they'll actually burrow in underneath your epidermis and they'll cause an itching sensation, and a really intense, annoying itching sensation. Now it usually occurs in between the fingers or at the joint of the wrist, that sort of thing, and it spreads easily around highly condensed or overcrowded areas or poor hygiene. It's also translated as field, is where scabies can spread really, really easy. Now, acne vulgaris is caused by a bacteria, but the reason it's defined as an other is it's associated with the androgen stimulants develops in the sebaceous glands, and that increases the secretion of sebum. So it's often associated with your puberty in young men. Okay, so as your androgen is released, it promotes this hyperkeratinosis, and that can actually block the gland and it forms like a hard plug. Okay, so because of the androgen being released, you end up increasing the amount of keratinosis, which can block it. Then as the sebum wants to build up, it gets a whole bunch of back pressure. Now bacteria will come along and actually colonize within this sebum, and you'll get a formation of a comedones, is what it's called. So just a large sac underneath the actual sebaceous gland. Now, bacterial lipase enzyme will break down fat in the sebum, and breakdown of this area will cause inflammation and then a formation of a large pustule. And then associated with chronic inflammation, during healing you can get scarring, leaving that scarring or discoloured appearance often associated around the face. Okay, we'll just look at a couple of other conditions that you may see. First two are basically interest-based ones. Okay, they're not really anything to worry about too much, and if you have a patient, they're definitely going to know that they have it. So albinism is defined as a congenital hyperpigment caused by a inbuilt error in metabolism. So you can no longer produce melanin. Now the most common form of it is recessive inheritance, and it's recessive inheritance along the sex X chromosome. Okay, so it is quite rare and difficult to get. Now you can have a look at the actual family tree there to see how it occurs. Now what a lot of people don't know is it actually affects people of all races. Okay, so there's not a particular race that gets it more than the other, and as I mentioned, the enzyme involved in the synthesis of melanin are lacking or non-existent. So if melanin cannot be synthesized, we don't get any pigmentation of our skin, and also our hair and retinas as well. Now, the main thing associated with albinism is obviously an increased risk associated with skin cancer from sun exposure. Nevi, also known as your birthmarks, is normal cellular tissue that is just arranged in an abnormal manner. Okay, so there's nothing abnormal in the actual skin itself, it's just arrangement is not as classically normal as anything else. So you can have what's known as a melanocytic or cytic nevi, which is your brown birthmarks, And then you can also have what's known as a port wine stain, which is the picture in front of you, and that's a congenital arrangement of small blood vessels. Like I mentioned, nothing particularly to worry about there. The last conditions we'll look at are ones associated with immunity. Now these are particularly interesting and very common. Now whilst it may look relatively simple on the screen, things like psoriasis, there's like 5 main causes or 5 main different classifications of psoriasis, and there's a whole bunch of overlapping immunity-based problems that you'll find with psoriasis. Now, psoriasis is defined or characterized by hyperkeratinosis of the surface of the epithelial. Now, whilst it used to be genetic and environmental factors mostly, they've found genetic links, as they have with a lot of things. Now these will mostly occur on the elbows, the knees, and you'll end up with a silver scaly appearance. Now it can occur in the nails, can also affect the scalp, and it can be a precursor to things like arthritis. Now, people often get flare-ups of psoriasis in response to trauma or emotional stress itself. So the way it works, just quickly, is you have a involving agent, obviously from genetics or environmental factors. Now what that does is does one or two things. It either activates your antigen presenting keratinocyte, or it comes along a different way and activates the antigen presenting cell. Now either way, this activates your T cell within your lymph nodes or your skin. Now, as a result of the activation of T cells, it obviously builds into your adaptive immunity. As a result of the adaptive immunity, the area that's involved is going to act like any other area of inflammation. So you're going to get a build-up of chemotaxis, you get a build-up of cytokines and vasodilatory response, which is going to cause your vascular alteration and proliferation associated with the keratinocytes. So keratinocytes are going to increase in their actual production, but because it's happening so rapidly, the body doesn't have enough time to give enough lipids to the area, and that's what gives you the scaly appearance. Now, as you can see at the bottom of the flow chart, it's a self-feeding disorder. Okay, because as a result of this increased keratinocyte activities, we have an increase in chemotaxis factors, which means more lymphocytic involvement, which is going to increase your cytokine release, and then it just continues. Okay, you get the vasodilatory response and proliferation, and it just continues. So people with psoriasis will often go through stages of flare-ups and then regressive stage, but they'll always suffer in some way from this condition. Now, during a flare-up, it's often treated by your corticosteroid-based substances. Now, the last one that we'll look at is eczema. So eczema is also known as dermatitis. So you contact dermatitis, or any form of dermatitis is what it's known, and it is an inflammatory disorder. Now, causative agents, as I mentioned, it can be exogenic, which is caused by irritants or an allergy. Okay, that's the one that we're looking at on the screen. The other one can actually be caused by an endogenic eczema. Okay, now we don't actually know what the main causes of those ones, but if we have atopic dermatitis or an autoimmune dermatitis, then they're your endogenic causes. Now, your clinical symptoms is your itchy lesions and secondary infections of the area, so you can get oozing, things like that. So looking at the progression of eczema, we either have an irritant or an allergy. But either way, it starts with some form of chemical exposure to the skin, which will either cause the activation of your cytotoxic T cells or the cellular activation of the innate immunity. So you'll either have innate immunity or adaptive immunity, which will cause cellular changes of the skin. So chemical toxicity will cause innate immunity, which increases the likelihood of necrosis, whereas your cytotoxic T cells will actually start attacking your keratinocytes and therefore bring in your phagocytosis. So obviously this again will result in a massive inflammatory response. You'll get chemotaxis, you'll get cytokine release, vasodilation, which breaks down the cellular activity within the area, okay, and can lead to increased apoptosis, okay, so cellular death. But the end result is going to be inflammation. Either way, the clinical signs that you are going to see is inflammation. Just know that it can either happen by an innate immunity or an adaptive immunity itself. Okay, so that's the end of pathophysiology of the skin. Like I said, there is way more that you can go away and have a look at. There are entire textbooks, professions associated with dermatology. So this lesson, like I mentioned, was mostly focusing on classic clinical features that you'll find and a few tips and tricks in order to provide better practice. Until next time, take care.